Thanks for coming in this afternoon or this I guess nighttime in the East Coast. So this is an AO trauma course, and we're going to be talking about Lisfranc's fractures and dislocation tonight. And we got we got a couple of great faculty here with us, and Dr. Sachs from Colorado. He's a residency director at the Presbyterian and the St. Luke's residency program, and he's also fellowship director at the program. He got a lot of knowledge in this Frank's fracture and dislocation, and also Dr. Raja, who's at the VA Medical Center today, but he almost entire life he was in the active military hospital where he treated a lot of the high energy Lisfranc's injuries and he actually did some research on this topic. So we got a great panel tonight. Just to go over the disclosures, Dr. Roger has no relationship, but financial relationship. Dr. Sachs have several, but we will not going to talk about any particular products or company for this webinar. AO North America staff is not involved with any companies. We also acknowledge that education activity is funded by the AO Foundation, and all the rights for the education resources and assets used is owned by AO North America and AO Foundation. I guess several disclosures, but again, we're not going to be talking about any particular products. So AO North America is an independent nonprofit surgical specialty society dedicated to improving the care of the patients in musculoskeletal injuries. AO does not endorse nor promote any products or service of the commercial entities. So we're going to be talking about Lisfrancs. We're going to talk about the subtle ones, complex ones, but very much these are the learning objectives. At the end of the session, you'll be able to list indications and contraindications of open reduction and internal fixation for the Lisfranc's injuries, as well as a primary fusion for the Lisfranc's injuries. So you'll be able to select ORIF versus arthrodesis in Lisfranc's injury patients. And we also talk about AO techniques and fixation techniques, what would be the best technique for what kind of Lisfranc's injury, also based on the risk factors and other factors as well. So here's a format tonight. So we're going to talk about a little bit about basics. I just spent a couple minutes on it. And then we go into the didactics. Dr. Raja is going to be talking about what are the indications for open reduction and internal fixation. So when and how and why you want to do the open reduction and internal fixation for Lisfranc's injuries. And Dr. Sachs is going to follow, and he's going to talk about when and how and why do you want to do the fusion rather than ORIF. And we're going to finish up with the case discussion. So we're going to talk about different types of Lisfranc's injuries, and then we'll try to apply what we learned from didactics to the actual cases. And we're going to finish up with questions and answers. Just to the future conferences coming up, AO North America has a whole bunch of courses, blended courses coming up in November 13th to 14th in Washington. More immediately in April, it's going to be a basic DPM course in Tampa, Florida, followed by advanced course May 1st to 2nd in Tampa, Florida. So if you're interested in those courses, I think the registration is still open. So let's get into it. So just wanted to, go basics before we get into the little more details about procedures and stuff like that. Obviously, Lisfranc's injury is tarsal metatarsal joint fracture and dislocations, and obviously the Lisfranc's joint is kind of complex, and I'm sure Dr. Raja is going to talk about it, but multiple ligaments and orientational ligaments plays a role, and what kind of injury, how do you fix those things? And obviously, there are a lot of classifications out there. These are real, all of, it's all, description of the type of injuries. It doesn't really show you the prognosis of the injury or anything like that. So for this course today, we want to really talk more about meaningful categorizations like subtle versus obvious Lisfranc's injury, open versus closed, low energy versus high energy, fracture versus fracture dislocation versus just a dislocation alone. Active patients versus sedentary, high-risk patient versus low-risk patients, because those are really more important when you try to determine what kind of procedure is best for the patient. We're gonna, this is a course, so obviously we're gonna talk a little bit about, how to fix those, what kind of hardware, what kind of technique is the best way to treat each Lisfranc's types. So with that, transfer. I'm gonna stop sharing this screen, and Dr. Rogers is gonna be talking about open reduction and internal fixation.
All right, folks. Well, thanks so much for the invitation, Dr. Shibuya and AO North America. We're going to spend about 10 minutes talking about Lisfranc injuries and how to treat them ideally with open reduction and internal fixation. So, objectives for this talk, understanding some general anatomy involving Lisfranc injuries, gaining a general understanding of the ideal circumstances for addressing these injuries with open reduction and internal fixation, and understanding surgical considerations to include fixation options, and the decision to either retain or remove hardware. Sometimes that topic does come up when you consider this sort of fixation. All right, so we just discussed it just a second ago. Our area of interest, basically, it's shouldered by the first met base of corresponding medial cuneiform and the second met base to the corresponding intermediate cuneiform. We look for general alignment of these joints to be intact. We also look for a general symmetry of the relationship between the cuneiforms and between the medial cuneiform and the second met base. This symmetry is important when looking for indications of an injury. The general location of the Lisfranc complex, however, is primarily between the medial cuneiform and the second metatarsal base. It's a complex, though, which means it spans the entire region. So keep in mind that the dorsal portion of this ligament is the weakest, and the plantar ligament, that's where you have more strength, more stability. It's far more robust. We're going to focus primarily on that. And so it's robust and because of its depth of support, these plantar TMTGA ligaments, it's a ligamentous tendus architecture. So it's robust because of its depth. It's robust because it extends beyond just the medial cuneiform to the second met base, also extending to the third and fourth met bases. And thirdly, because it's reinforced by tendons as well. For example, the peroneus longus tendon, portions of the tibialis anterior tendon, and the tibialis posterior tendon as well. So who is the right patient for a Lisfranc ORAF? Well, the answer really comes by way of extrapolation from both retrospective and some prospective case studies. So I'll present to you the ideal patient that could undergo this. So I'm going to really just talk about two articles. This is the first one. This is a follow-up to Dr. Coetzee's first article, which most of you probably know in 2006. But to his credit, he published this a year later, where he actually outlined both indications and contraindications to fusions. And so the extrapolation we'll take is pretty much for the contraindications. And the two I'm going to focus on are the subtle injuries and the unidirectional injuries. So what's a subtle Lisfranc injury? Well, basically, to put it in simple terms, a subtle injury is what we call a latent injury. This is where the x-rays on initial view just look pretty much normal. Nothing looks abnormal or wrong with them. And it typically takes additional testing, such as a contralateral film. So contralateral films are very important of the uninjured side, or a stress examination to demonstrate some sort of injury occurring. In this case, a forefoot abduction test demonstrated gapping of the Lisfranc region and the first med base cuneiform joint. On the lateral view, these subtle views look normal as well. You basically have fairly well aligned medial column with alignment of the joints corresponding from the metatarsal to their corresponding cuneiforms. And the second article I want to talk about is the one by Dr. Nunley, where basically he talks about the fact that on a weight-bearing film of the injured side, you will not appreciate any loss or decrease in arch height as compared to the contralateral side. And this he measures by looking at the plantar aspect of the medial cuneiform to the plantar aspect of the fifth metatarsal. And what this represents, if it is present, meaning no loss or decrease in height, is an intact plantar ligament architecture. So this is basically how you can be assured that your plantar ligaments are part of your construct. The second type of injury are these unidirectional Lisfranc injuries. So what you basically have here is something more obvious. We see a diastasis, for example, between the medial cuneiform and the second met base, indicating disruption of the Lisfranc ligament complex. The other joints, however, involved could be the first met base as well, as far as slightly being displaced, but the remaining metatarsals and their corresponding cuneiforms or cuboids seem to be intact. Once again, though, in these injuries, we consider them to be, let's say, frank diastasis, where there's no stress examination needed. You can kind of tell just on the x-ray that there's something going on. But the key is that it is unidirectional. And what that means is that you're only going to pick up on something being wrong, in this case, in the transverse plane on the AP view. On the lateral view, things still look normal. Once again, pretty well aligned medial column and no decrease in arch height, once again indicating that the plantar ligaments are considered to be intact. So the first criteria basically for the ideal patient for an open reduction to fixation is going to be someone with either a minimal, i.e. a unidirectional injury, pretty much evident on the AP view in the transverse plane, or someone with no displacement, i.e. a subtle injury, which has to be brought out via further testing or comparison. And also on the lateral view, you don't have any appreciable collapse in the arch height, which indicates that you do have an intact plantar ligament architecture. The second thing you can extrapolate as well for the ideal patient is someone with limited to no intra-articular joint involvement as far as fracture. So for example, here we have an intra-articular fracture of the second met base to the intermediate cuneiform. So this wouldn't be the ideal patient because this sort of injury can, based on the demands of this area, lead to post-traumatic arthritic changes, which can be symptomatic in an ORF situation. The third thing to look for is basically someone who's undergone minimal to no forced contact pressures across these joint surfaces. So basically, before you get to the surgery, they've been off it. They haven't been walking on it or trying to walk on it. And that's because when you have in this situation, we have this unidirectional injury, we have an uneven match of the joints. And so if they were to weight bear on this, it would not only would be symptomatic or painful, but you have certain parts of the joints not undergoing contact pressures and some parts of the joint undergoing excessive contact pressures. And we know that uneven contact or joint contact pressures typically lead to an accelerated process of cartilage degradation. So keeping them off it ideally is the way to go until you get to fixation. So these are basically the three primary commonly agreed upon criteria for the ideal Lisfranc ORF patient. Someone with minimal to no displacement, someone with limited to no intra-articular involvement, and somebody who's been minimal in terms of forced contact pressures across the joint surfaces. So when it comes to ORF, the one thing everybody pretty much universally agrees upon are these two criteria. You want to achieve anatomic reduction, and you want to achieve do this via stable fixation. This is something that, like I said, everyone pretty much across the board will agree upon in the literature. A note about the surgery itself. Typically, when we get down to the deep fascia, this is when we sort of take our blade and go down to bone or go down to the osseous structures. Keep in mind that the neurovascular bundle, in this case, the dorsalis pedis artery and the deep peroneal nerve are lateral to the dotted line in this case, which is ideally where we typically go to get to our target, which is going to be that space between the medial cuneiform and the second met base. So keep in mind that the bundle is lateral to this structure or this anatomy. So in this case, you can see when I've gotten down to this area, whether I have diastasis, subtle injuries, or not much diastasis, I will go ahead and bring that area together using a point-to-point clamp. In this case, I'm using a perimeter plate to fixate this injury. But typically, I'll magnify the x-ray at this point to observe this on x-ray as well as I'm looking at it as well. And I'll use a FRIA elevator to kind of put that elevator into certain areas to make sure I have good tight compression. One thing also I'll do at times, if I feel that the intermediate cuneiform is elevated, I may go ahead and take a bone tamp and push that down, basically re-engaging the intermediate cuneiform as part of this sort of a keystone of the arch, and with re-engaging it, providing more stability to this construct. So there are various different ways of performing an open reduction to fixation. You see you have options here that include a trans-articular non-compressive technique where the screws cross the joints. You have a non-articular compressive technique. You also have various pinning techniques that are either transarticular or non-articular. Those can be used at times for just provisional fixation, or at times when the patient cannot afford to have a big incision made or has medical issues where you have to do something sort of immediate to stabilize things, then pinning becomes a very good option. Of course, you can use plating, bridge plating, or perimeter plating. And of course, there are hybrid techniques as well, combining various aspects of fixation together. But once fixation's been achieved, the next question typically is, should we remove the hardware in these Lisfranc injuries? And I can tell you that in general, typically people go into these cases with the idea of planned hardware removal. Somewhere down the line, they're going to take this hardware out for various reasons. So something to keep in mind is this, that when you can select an open reduction to fixation as your procedure of choice based on the case at hand, you're really the rate limiting step. You're relying on ligaments healing and remodeling. That's really where the eventual support and stability would come from if you remove the hardware. And so typically when you have an injury like this, the body will initially lay down type 3 collagen, and then over time it will remodel to type 1 collagen, which is far more supportive. And so this takes approximately a year, if not more. So it takes about a year for this remodeling phase. So ligament repair and remodeling is a prolonged sort of process. It's prolonged healing time. When you look at various articles talking about how long they'll take before they remove hardware, it's sort of all over the board. 3 to 6 months, 6 to 16 weeks, 120 days, but all of them generally are under 1 year, which is interesting because, as we know, it takes about a year, if not more, for the ligaments to remodel. This article, I just want to mention it. This was an article that basically looked at 61 patients who had retained hardware at 1 year after an open reduction to fixation. And they found that basically 80% of these people did not have any failure of hardware or reasons to remove hardware. So basically, it just concluded that routine hardware removal for these injuries may not be necessary. So it gives you the idea now or an option to consider maybe an unplanned hardware protocol where you don't take things out unless there's a need to take them out and you just basically leave them in. And so the take-home messages basically for this talk and the ideal Lisfranc RF patient would be someone with either minimal to no displacement and with an intact plantar midfoot ligamentous architecture. Second, minimal to no interarticular involvement, ideally no interarticular involvement, and to avoid any excessive weight bearing prior to your operative intervention. Third, intraoperatively, you want to look to achieve both anatomic reduction and stable fixation. And finally, you have two options. You can go with either an unplanned hardware removal where you plan to leave the hardware in. That's typically what I do. It just adds more to the stability of the construct. Or you can do a planned hardware removal. But if you do, maybe consider at minimum keeping things in for at least 12 months before you remove the hardware. This allows for more time for the ligaments to remodel. And I'll give it back to you.
Thank you. Thank you very much. Again, if you have questions, please put that in the Q&A box on the bottom. I don't think we have the ability to connect the microphone with the participants. So if you have any question, please type in the Q&A section. So next talk is going to be, so when and how and why we do the arthrodesis right away. And Dr. Sachs.
Thanks, Dr. Raja. That was a great talk. And moving into when, how, and why we want to fuse it. And so, I think this topic has been pretty heavily debated in the literature, recently and quite some time. I think it really, the controversy exists, regarding really the optimal treatment. And I think, really when you're looking at these, it's very similar to calcaneal fractures. And I think that a profession as a whole has really tends to lean one or way, depending on the literature, the outcomes, and the philosophies that have been developed in the literature. And I think it's relatively split down the middle as far as whether we're looking at ORIF versus arthrodesis. I think it's important to realize that, obviously we're talking about more acute injuries here and not really chronic. I think most would agree that chronic Lisfranc injuries most likely are going to develop arthritis and most likely require fusion at some point. But just to get into it a little bit, and I wanted to bring up this relative motion of the tarsal metatarsal joint. I think some of the issues and or controversies that come up when you're talking about fusion of these joints is, the more that you fuse, the more stiff that your foot may become. But if you look at really truly the biomechanics, there's really less than 3 degrees of motion in the first, second, and third tarsal metatarsal joints. Now, when you get up into the fourth and fifth metatarsal joints, you may get up to about 10 to 11 degrees, which we all know is controversial on whether we should fuse these joints. But I think it's an important concept to realize that, determining whether the appropriate surgical option, whether it's ORIF or fusion, I think, we're dealing with relatively low motion across these joints and may not be as much of an issue as we may consider. So, let's get into it. We'll start talking about fix or fuse and why we may want to pick one or the other. And so, traditionally speaking, when we looked at these joints, involving ORIF, I think we've been using mostly transarticular fixation, bigger incisions, more hardware, the better. And then I think you have to think about, are we actually causing more injury to these joints and possibly increasing the risk of post-traumatic arthritis? And so one interesting article that talked about transarticular fixation, they were thinking about what's the real true cause of post-traumatic arthritis. And the purpose of this study is really to determine whether the involved joint surfaces, is there, every time that you reposition a K-wire or put in a screw, are you really causing more damage? Now, this was an interesting cadaver study. And essentially, the authors found that the more often the K-wire was repositioned, the more damage was done to the joint. And, I think most of us would agree probably a 3-5 or maybe a 4-0 screw is appropriate for these. But it makes you think, the more transarticular fixation you use, are we actually causing more harm than good? And so, for the past several years, I think ORIF has really been standard with pretty well-established technique, but I think there's definitely a trend towards more primary arthrodesis for a few reasons. And so I think first, there's been a tremendous variability in these injuries. Really, no two are the same. We know that no matter how perfect our reduction, these patients are most likely going to get post-traumatic arthritis. And then you also have to think about economics. Dr. Raja mentioned about maybe we don't need to remove the hardware, but if we do require hardware removal, that adds more time, that adds more cost, and maybe potentially primary fusion may be better off to begin with. And so one interesting study looking at whether fusion is a trend, and this was a systematic review of 11 studies, this was back in 2010, but they looked at evaluating the role of ORIF in the management of these injuries. This was from 1985 to 2010. They had a little over 257 patients, or a little over 250 patients. About 50% of them developed post-traumatic arthritis. Only 8% went on infusion, but it gets you to thinking, is primary arthrodesis maybe a better option? And so when you're looking at these and thinking about the types of fixations, I think there's a few things you have to consider. And so first, obviously, early recognition of these. A lot of these are misdiagnosed, and the sooner we get these diagnosed, the better off they be. But we have to think about what type of injury we're looking at. Is this a subtle injury, which I think can be, relatively difficult sometimes to diagnose? Are they higher energy, purely ligamentous, or really neglected injury? And obviously, that's more of the chronic one, which we're not going to spend much time on. But I think you have to look at these all differently. I think most of that controversy sits when it's primarily an unstable and/or an entirely ligamentous injury, whether these are intra-articular, extra-articular, how much comminution there is. And I think all of these things are things that you have to think about. And then obviously you got to think about the patient, whether age, health, activity level, all those things come into play when we're talking about choosing the right option. And so why do we think about arthrodesis? I think, again, fusing these non-essential joints are well tolerated. You don't really lose much motion within the foot, and ultimately may be a better option. It does reestablish the alignment and position of the foot. Obviously, we want to look at the medial and central columns, as Dr. Roger kind of mentioned. Realigning and obtaining anatomic reduction is really the most important. And then imparting stability to that first ray medial column can really stabilize the foot and give us a better overall result sometimes. And so a couple of studies looking at, really there's very little studies or articles that directly compare ORIF to arthrodesis. A few studies to look at, one from 2012, a systematic review. They looked at comparing ORIF to primary arthrodesis, about 190 patients, 1-year follow-up. But they concluded that there was really no significant difference as long as the patients had anatomic reduction. Another study from 2009, this was a prospective study of 40 patients. They showed no difference in patients' physical functioning and patient satisfaction primary arthrodesis and ORIF groups had really similar satisfaction rates. Another couple of studies, Lyon Coetzee in 2006, another prospective study, 41 patients, 20 had ORIF, 21 had an arthrodesis group. The arthrodesis group fared better with better AOFAS scores and a better pre-op return to activity. Another one from 2002, these looked at more severe studies or more severe injuries. 12 of those patients had primary arthrodesis, 16 had ORIF. There was no difference between the groups, but really no big surprise. The patients that had complete arthrodesis did worse comparing those to the ORIF patients. One final study to look at, this was 61 patients from 2016. About half were treated at ORIF and half with primary arthrodesis, but they found that patients that had post-traumatic arthritis in the ORIF group was found to have about 71% or 72%, but about half of those were symptomatic. So interesting things to look at. And so when we're talking about which fuse joints we wanted to fuse, I think it depends on obviously the location of pain and injury, how much deformity and misalignment there is, what kind of joints involvement we're looking at. I think, again, as I kind of mentioned, joints, the first and second and third tarsometatarsal joints are pretty well tolerated. I think the controversy comes when we're looking at the fourth and fifth joints. Obviously not ideal, sometimes necessary, but we want to try to avoid those when we can. And so some of the basic surgical principles when you're looking at this, I think when you're talking about fusing the joints, you want to try to remove any fibrous tissue as much as you can, remove the loose bodies, try to remove any interposed tissues that will obviously increase rates of fusion. And then reducing that first and second metatarsal base, I think that's really the most important, trying to obtain anatomic reduction, get direct visualization, and then obviously looking at maybe Lisfranc fixation, as Dr. Raja mentioned, and then fixating and or fusing any of the other joints as we need moving down the line. And so one of the main things as far as surgical principles, again, is anatomic reduction. And I think most studies will show that when you have anatomic reduction, you'll have up to 95% better relief and good outcomes. When you have non-anatomic reduction, as low as 17% has showed good outcomes. And then, again, thinking about what is really anatomic reduction, in my opinion, it's really reducing that first and second metatarsal base and maintaining that medial column as best as we can. Just to mention the controversy of the fourth and fifth tarsometatarsal joints, I think most would agree that we want to try to avoid that as much as we can. Obviously, it's required if we have to fuse the first, second, and third joints. It's required really for mobile adaptation of the surfaces, and I think reducing that with more temporary fixation is probably going to be a better overall outcome. A couple of studies, one from 1996, a bit of an older study that basically recommended avoiding. Dr. Derner in 2020 ultimately had relatively good satisfaction rate, about 89%, but about a 10% non-union rate, which is not ideal. But when we're looking at fixation of these, obviously we want good fixation concepts and following standard AO principles and techniques. Try to create a rigid, stable construct so that you can produce good fusion. There's all kinds of different options, screws and plates, different kinds of plates to use. And then compression staples are also an option as well. But when we're talking about some of these things and what are our options, thinking about fixing or fusing these, I think whether you're talking about ORIF, partial fusion, complete fusion, I don't think there's really compelling evidence to exist that really globally favors one or the other. I do think whether we fix or fuse, whether again it's partial or complete, I think you have to look at each injury differently because no two are created the same. I think you have to look at whether it's osseous or soft tissue. And therefore, I think there's no great one size fits all when it comes to these types of patients. But so what are some of the things that we can do to help? I think considering extra-articular fixation, if you're going to do that, I think that's perfectly reasonable. I think primary arthrodesis is possibly and probably the trend, but I'm not sure it's totally acceptable at the moment. Again, anatomic reduction is key, but I think you have to realign that second metatarsal and medial column in order to um, get the best result that you can. Again, I think the issue is more complicated than a blanket approach. Giving there's all kinds of different things, high and low energies, number of joints involved, ligamentous versus osseous, and all the things that we have to consider. But I thought I'd show just a couple of cases here that I had recently, and just wanted to look at some of the things that I've considered when we're looking at fusion. So here's a 35-year-old male. He had fall from a height. He's an avid skier and hiker, pretty classic patient that I see in my practice. But you can see there's multiple uh, uh, injuries through the first and second tarsal metatarsal joint, a relatively large intra-articular fracture here. You can see a intra-articular fracture of the first metatarsal base. Here's looking at the CT scan, but you can see transverse fracture through the second and third tarsal metatarsal joints, relatively involved. Same thing again, you can see that first metatarsal base avulsion fracture there. And I felt he would be better suited with primary fusion of all three joints, and ultimately did well. And took a while to get there. These are all pretty bad injuries, and but 3 to 6 months later, he's doing pretty well. Here's another lady, 35-year-old female. She had a fall down the stairs, multiple fractures across first, second, and third tarsal metatarsal joints. There's actually lateral dislocation of the fourth and fifth tarsal metatarsal joints. There were no fractures involving the fourth and fifth tarsal metatarsal joints, but we chose to primarily reduce 4 and 5, and then primary fixation and fusion of 1, 2, and 3. Ultimately, this was 6 weeks later, and then 9 months later with good complete fusion after removing the K-wires. And so some take-home points to think about. This is sort of how I look at it moving along. So these are subtle with minimal offset. I think looking at a primary ORIF or percutaneous repairs is pretty reasonable. I think most of us would agree that if it's high energy, comminuted, intra-articular fractures, I think these tend to be better suited by fusion. Ligamentous, I've leaned more towards fusion, especially if they're dislocated. I find that they are relatively unstable, and maintaining that over time with just ORIF, I think ultimately results in instability and arthritis. And then again, neglected, I think we'd all agree to fuse. But again, last point, anatomic reduction is key in these, and I think ultimately will dictate your ultimate success.
Thank you, Brad. That's
Thanks,
great.
everybody.
Okay, I was told that the Q&A box may not be working. Not sure, but I got a text on my phone regarding a question on some people advocate just isolated second tarsal metatarsal joint fusion rather than always fusing the first and second. Do you guys have any experience just like isolated second tarsal metatarsal joint arthrodesis in these cases?
I don't. I find that most of these have some layer of first-ray instability, and I have not done an isolated TMT joint fusion for a true Lisfranc injury. Now, obviously, I've done it for primary arthritis, but not just a Lisfranc injury. Again, I just think majority of these cases involve the medial column.
Yeah, same experience here. If I'm going to fuse something, I usually find injury more expansive than just a second MTPJ. One thing I do though for those subtle injuries that I've done lately is I've also, the region between the medial cuneiform and the second met base in these subtle injuries, I will sort of prep them as well, make them a little rough in a sense, and kind of spot weld those two areas together to get a little more stability out of it in case the hardware has to come out or just giving that area. Because stability is really the key factor here. There is some mobility involved with that region to some extent, but stability is really where it's at. So you want to try to maintain that.
What do you think the trend is? I mean, obviously 2006 when the first paper came out, everybody kind of jumped in the bandwagon and just started fusing everything, right? And that was my first year out, 20 years ago. And, certainly my patient population had high risk patients. So, I did a lot of arthrodesis, but more lately, we get more paper that come in now and, show that not much patient satisfaction difference between those two procedures. What do you think the trend is going? Obviously, each patient is different, but since Brett mentioned some trends, so.
Yeah, I'll take that first. I think because techniques have gotten better, and you're talking a paper from 2006. I think we have better options. I think bridge plating is a little more common. I think we're trying to avoid joints and screws across joints. So I think in the right patient, again, obviously different patient, different situation, but all things being equal, if it's a healthy patient, younger, active patient, and there's no intra-articular joint involvement, I would be more inclined to try to do an RAF. I think once the joint's involved, especially if it's comminuted, I think it's not a matter of if, it's a matter of when you're going to fuse that joint. And if it were me, and this is sort of how I present it to patients, I'd much rather be fixed and done and fused and knowing that we're going to be um, done with that case, if that makes sense.
The only thing I'm going to add to that, and I agree with Dr. Sachs, is that sometimes what we tend to do or trend to do sometimes is dictated by industry as well. So, with the introduction of flexible fixation, these things were now called sports injuries or Lisfranc sports injuries. The subtle ones they had like rebranded in a sense. So you see a trend going in that direction. But ultimately, if you stick to the founding principles of the fact that for these subtle injuries, in young healthy patients or healthy patients, maybe they're not as young. If you can stick to those two principles of good anatomic reduction and stable fixation, and over time they generally tend to do well as long as you wash the joints out and look for other things too. But but otherwise, trend-wise, I think it just comes down to other factors that may influence the decision. But these founding principles that we've discussed tonight still should maybe drive your decision to go in one way or the other. I personally used to perform a lot more open reduction tone fixation. It was that 2006 article by Coetzee that sort of opened my eyes to the fact that these maybe should be fused. I did have the ability to see these patients post-operatively for a while, and granted, a lot of them did end up what they call medically boarding out of the military. But the goal was always that they could walk. We weren't expecting them to run again or march again or jump out of airplanes again. But if they could ambulate relatively without a lot of pain, then that was the goal. And for the by and large, most of them could do that. But there was a subset of people that had to go on to fusion. So it became very much a stage thing. I actually have a question that came up in the box.
Yeah.
I can read it out.
Yeah.
So before going to that, just for those of you not familiar with the first paper in 2006, it was the randomized clinical trial, the first randomized clinical trial, and that was actually favoring the arthrodesis, but it was transarticular
Yeah.
fixation, screw fixation. So traditional technique, and obviously that crosses the joint, maybe
Mhm.
more chance of getting arthritis. Today a lot of people are doing bridge plating. And obviously, the other point I wanted to make was that that study actually that the follow-up non-weight-bearing status was only for 6 weeks for both groups. So Dr. Rogers' point, the ligament takes 1 year to remodel. So maybe weight-bearing those patients in 6 weeks,
Yeah.
especially for the ORIF group, maybe too early. Therefore, biasing towards more arthrodesis group. Okay, so the question is that which fixation do you guys prefer? Screws, flexible plates? I assume this is for the open reduction internal fixation.
I tend to go with screws and plates. I'm not a big advocate of flexible fixation. I've had a few cases where flexible fixation has failed. Now maybe it's because the population I was dealing with, maybe the demand they went back to was a little much for the flexible fixation. Sometimes bone quality played a part in how well it was able to keep reduction in place. But to me, the guiding principle always for this area is stability, and so I feel like rigid fixation, non-transarticular fixation, compressive in nature, whether it comes through plates or screws, is ideal for me.
I think it kind of depends on the situation, obviously, but if I'm trying to salvage joints and it's ORAF, I try to use mainly plates and avoid crossing joints in any way. I think crossing joints you potentially could cause more damage. Now, the only difference is I'll obviously use a screw for the Lisfranc screw from the medial cuneiform into the second metatarsal base. I have on occasion I kind of liken it to a syndesmotic screw where sometimes I'll take the Lisfranc screw out and use flexible fixation in its place, knowing that the ligament can take a long time to heal, right? So if I'm going to try to salvage a joint and do an RIF, maybe take the screw out at 3 to 6 months and then replace that with flexible fixation just to maintain that correction and maintain that ligament for a longer period of time. But I tend to lean more towards plates, mainly for fusions and bridge plating.
So obviously the rigidity is good, but too much rigidity is not good, right? I mean, obviously flexible fixation, it's been shown in ankle that it's actually good for ligamentous, more the micro motion uh, allows better, more physiological healing of the ligaments. So in this Frank's area, do you think, I mean, it's not like a black and white, but do you think that the flexible fixation in Liz Frank's ligament area is too flexible?
Um, One of the things I think about is that the forces and the biomechanics of the midfoot is a little bit different than in a syndesmotic scenario where you have more axial load. In the midfoot, you have sort of this bending force where the heel, I mean, the gravity's pushing down, the heel is off the ground, the forefoot's on the ground, and you have this sort of bending force in the midfoot. So I think that does change the dynamic for me just a little bit, and I prefer a little more of a rigid construct. I like the idea Dr. Sachs had. Sometimes you could back something up with flexible fixation if you've given it time to heal. But I did that more in the ankle than I did in the midfoot. For the midfoot, for me, it's still that bending propulsive gait scenario still doesn't really justify enough for flexible fixation. Although it may have great success for some of our other colleagues out there that they're doing it on a routine basis. But for me, it just hasn't quite crossed that threshold yet,
Yeah,
based
I
on
would clarify.
dynamics.
I wouldn't use it primarily. Primarily, I like the screw across
Yeah.
the traditional screw across the Lisfranc ligament. But if I'm removing hardware and I feel
Yeah.
like I just need a little extra stability, I realize it's flexible stability, but still stability. I think using that flexible fixation for me has been a good option.
Yeah, I agree. I saw it that way that, the way you were describing it. That's what I was thinking. As a backup.
Yep.
All right, with that, let's actually that was a good discussion. Let's apply that to the real cases here. Um, so this is a 35-year-old male fell from the truck, back of the truck, and this is only 3 days. He's a healthy guy, no past medical history. Typical edema and ecchymosis in the medial arch area. Obviously, the midfoot pain. This is a Lisfranc's course, so obviously there's something going on with Lisfranc's. So as you can see that it's a little gapping. I don't know if you call this a subtle because it's non-weight bearing film and still see the gapping there. So what would you guys do for this case?
I see it as a unidirectional type of injury because the gapping is, um, from to me, it's obvious that there is something going on between the medial cuneiform and the second met base. It helps to know that this was, I'd say, between a low to moderate energy injury. It wasn't a fall from a high height. It was from the back of a truck. Um, the mechanism justifies this potentially occurring, based on how it planted. The lateral view looks fairly, it's a non-weight bearing view. I tend to get a weight bearing view if I can tolerate it, and a comparative view of the contralateral side. So that's another, tip I usually take into place. But it has ecchymosis, probably has some bruising planarly, potentially, and typically their pain is localized to that area. So the envelope, meaning the soft tissue envelope, is usually reasonable to consider if you need to make incisions. So, low energy to moderate, maybe unidirectional, intact plantar ligament envelope, hopefully, and compared to the other side, probably shows that construct.
So, what, non-op or operative?
Oh,
Um,
so yeah, so I would consider operative intervention in this case only because I feel that there is still enough diastasis to create uneven contact pressures between the second met base and the intermediate cuneiform. The first to the medial looks reasonable on this case. Of course, you could probably stress in the operating room and see if you get additional gapping, but you
Well, I'll take over at least for my thoughts. For me, I'm a fan of advanced imaging for these cases. I would consider an MRI or CT scan prior to making any decisions. I think it just helps provide some information like are there any interarticular fractures? Are there any occult fractures that I can't pick up on an X-ray? And so, assuming that we're just looking at a subtle injury, there's no interarticular fractures. I'd likely stress it intraop, and assuming that first ray is stable, which I would probably assume it was in this case, I'd likely do a percutaneous repair with a screw, Lisfranc screw from medial cuneiform into the second metatarsal base, and potentially another screw into the medial into the intermediate cuneiform just to further stabilize the area.
okay, yeah. So what about, I don't know if Dr. Roger is coming back, but would you consider flexible fixation here?
Probably not. I'm not a fan of flexible fixation primarily. I believe we want stability. I think the ligament, as we know, it takes a long time to heal. I can't, I'm trying to think, I can't say I've ever used flexible fixation primarily. And if I did, I don't use it anymore. This would be a good case for me that I would likely plan on taking the hardware out and replacing it with flexible fixation down the road, 3 to 6 months later. But I probably would not go primarily with flexible fixation.
So in terms of cost effectiveness, do you think a screw is cheaper, um, considering that there's more chance of removing it, right? Because flexible, you could just leave it there.
Yeah,
Secondary surgery may be less.
yeah, I totally agree. I think it's definitely something to consider. However, if I feel like the flexible fixation is not going to get me the result that I want, that's more cost, right?
Right.
Repeating a process that didn't work the first time would be more costly. Now, I definitely think there's some argument to leave hardware in, and I know that's probably more and more the trend nowadays, or letting it break or pull it out when it is a problem. I tend to plan on pulling out hardware or removing hardware for these Lisfranc injuries, again, somewhere around that 3 to 6 month range. But it's definitely a conversation. Again, I just don't know if flexible fixation primarily, I think this is a little bit more than the subtle injury. I just don't know if I would be comfortable using that primarily.
So Brett, any pearls for young surgeons? Any tips?
I think the couple things. One is always be prepared to stress these intraoperatively. I think that's a great thing to do, and especially it can give you some really good information, live information about what's truly unstable. MRIs and CTs can provide really good information, but Dr. Raja mentioned a couple of times that stability is a key, and I think you have to be prepared to bridge plate this if the first ray is unstable um, be prepared for other options, even though your primary option or plan is to do percutaneous repair. I think, it's always a good idea to have plates available or have other options available because you never know what you can see when you start stressing these. So I think having some other options is a excellent pearl.
So, I mean, that's- so that's exactly what I did percutaneously. I didn't order MRI or CT scan. Um, but yeah, obviously, I mean, it did well and it broke. Do you have any reason to remove it if the patient doesn't complain about it?
You know, this is probably more of my own philosophy. I have zero studies to back this up, but personally speaking, I wouldn't want a broken screw in my foot or my ankle, and so I tend to remove them before they break. Now, I do know that there's lots of opinions about leaving in broken hardware or leaving them in and letting them break. I think it's 100% perfectly reasonable. I just personally speaking, my most personal opinion, I wouldn't want a broken screw, so I tend to remove them. But if it's at this point they're broken and they're not symptomatic, then absolutely leave it in.
Yeah, I tend to leave the hardware in as well. Uh, Point here is you see how that screw did break. And this is kind of like why I don't use a lot of flexible fixation initially, because there is a certain amount of stability needed for this area. So this sort of indicates why I typically don't go with flexible fixation as a initial option, or I wouldn't do that, but based on the question that was asked earlier. But I also, typically will place another screw between the cuneiforms as well. I feel sometimes there is some instability in that region as well as the Lisfranc region. So it just provides a more stable construct to the area. So it's typically two screws, one being the home run screw you have here. It can be thrown in either direction depending upon your approach, and then one from the cuneiform to the intermediate cuneiform as well, as a very minimal construct.
Question from the audience, how difficult are these to remove after they break?
Um, the portion that you broke that's approachable immediately is reasonable, but the remainder in the second met base, maybe even going to the third, is challenging. I don't think it's worth boring a hole and making the thing more unstable or even fracturing things to get a piece of hardware out. I think you're simply asking for more, and making something more complicated in that sense. So I say take out what you can and leave the remainder in, and there's really nothing more to it than that.
Yeah, that's another reason why I don't like to let screws break because sometimes the broken screw, although the obviously the more proximal, however you look at it, the headed part of the screw is the easy part to take out. The other part that's buried in the distal or lateral cortex of the second metatarsal is the one that would be a little bit more difficult, having to make another incision, or is it partially buried in the third metatarsal? So those are when it becomes a little bit more difficult. Um, so sometimes they're never a problem, but sometimes they can be a problem, and I try to avoid that when I can.
Yeah.
All right, 44-year-old male with motor vehicle accident this time, a little more higher energy. Still healthy, no past medical history, but
Good.
he's a border patrol. I know your typical patient is skier from Colorado, nice and
Right.
healthy, but
Yeah.
you're either border patrol or people jumping off the wall. So that's what
We're
we.
out of the truck.
Yeah. So this is obviously different. Just to explain what we see in this is obviously higher energy, homolateral, but it looks, purely ligamentous. So to Dr. Sachs' point, would you do arthrodesis in this patient?
I definitely would lean towards it. Now, obviously, the smoker part of it brings a little bit more complication involved. This is higher energy. This is a significant ligamentous injury. If it is truly ligamentous, again, I think this one definitely warrants some more advanced imaging. Whether you argue CT or MRI, I think that sometimes can be personal preference. But if there's no intra-articular fractures, um, given the smoker history, I think it is reasonable to consider doing a um, purely ORAF. In my hands, in my opinion, I would lean towards fusion in a patient like this, especially with the instability of 4 and 5, the dislocation of 4 and 5. I think that they would stabilizing the first, second, and third tarsal metatarsal joints would indirectly stabilize 4 and 5, and I think they'd have a better overall long-term result, assuming we can get the smoking under control and assuming we can get it to fuse.
So Dr. Raja, I mean, you worked for the Army. This is federal service again, and uh, considering you're more pro ORIF. I mean, can this guy have overinduction internal fixation? Purely ligamentous.
Typically, can you hear me? I'm sorry, man, for my connection. But typically, this is a case that initially we may take to the OR and get it reduced and just pin it in place. Pin it and give it chance to the soft tissues to recover, because typically that is the issue with these. They're pretty swollen, the tissues are tenuous, and with his history of tobacco use, it's not ideal to go in initially and maybe fuse it. These cases in the past for us have been sort of 50-50. They haven't really all done well. So I did over time lean towards fusing these ultimately because it tended to do better in the long term, even for that baseline ambulation on a day-to-day basis, not having as much pain. Because this much dislocation and injuries to the soft tissues and to the joints themselves never tended to come back the way you would hope it would. So fusions became sort of a staged approach to these ultimately if you didn't fuse them off the bat. So ORF in these cases became provisional and sort of wire fixation, and then given it time and then going back and performing more definitive fixation, typically trending towards fusion later on in my career at Womack.
So do you guys think that the fracture dislocation has better prognosis than purely dislocation patients? Or the
If
same?
if you're comparing directly ORAF to fusion,
No, just yeah, I mean for ORIF, for open induction internal fixation. For fusion,
for
probably the same, right? About
yeah,
yeah.
I think I personally think purely ligamentous injuries are more challenging,
Yeah.
only
Mhm.
because I think they can be a bit more deceiving. You can look at this and say, all right, well, there's no fractures. If I stabilize that and get the soft tissues to heal, maybe I can salvage those joints. But I would argue that you'd probably start seeing arthritis in those joints within 6 months, maybe even 3 months. So I think personally, I think ligamentous injuries, purely ligamentous injuries, are a bit more challenging from a managed standpoint. But if you primarily fuse it, then you're ultimately going to get the same result. I just think from a decision-making standpoint, it can be a little bit more challenging.
Yeah. Agreed, because once you disrupt the plantar architecture and ligaments plantarly start to become compromised as well, then you're talking about a very prolonged, if at all remodeled outcome, probably not going to happen. So you have instability inherently built in. When you have fractures ahead of the injury, sometimes that's almost like absorbing the energy before it gets to the joint and disrupts ligaments. So breaks can sometimes be helpful to not sustain as much soft tissue disruption. So I agree that sort of purely ligamentous injury, especially a multi-directional instability, where you see it both in the lateral views and the AP views, that typically will end up being fused better because the rate limiting step is the fusion, which is what you're looking for in terms of stability.
Yeah, I actually fused it too. So I use the screws for this, obviously, but do you think it's better to have plate fixation, or if it's fusion, then casting them, it doesn't matter?
Yeah, personally, I don't think it matters. I think it's just personal preference. If all things being equal, bone fuses the same whether you're using screws or plates. I think as long as you have good fixation, good stability, good reduction, whether you use screws or plates, I don't think it matters. I think it's just, again, personal preference.
Yeah. Screws can, yeah, I agree. Either one is fine. I've done, plates, screws, staples, perimeter plates, hybrid constructs. Principles are pretty much the same. Once again, reminding everyone that anatomic reduction, the sequence which you use to get your reduction, and observing it intraoperatively, having the visibility to see it, and then stabilizing it however you feel comfortable doing that based on repetition, experience, or what you're comfortable with as far as your construct.
So what's your sequence for example, this case? Which one do you try to reduce first?
Typically, it does help when they're, sedated or relaxed. You can sometimes get some CT scans can show you sometimes when things are hinged or locked in. But typically, the second Met base to the or the Lisfranc region is my first go-to. Brett, why don't you go first, and I'll
I,
just
I'll,
listen,
I'll
and then I'll jump
sure
in.
I'll pick up. So yeah, so my what I basically try to do is, assuming that we're going to fuse these joints similar to what Dr. Shaboya did, I would free up all the joints I'm planning on fusing, and that would allow for some mobility of those joints. These are traditionally not very easy to reduce. They're dislocated, there's debris, there's soft tissue that's in between these joints. And so even though we think, oh, we're just going to put these back into place, traditionally it can be relatively difficult. And I find that, if we're fusing these joints and debriding the joints, loosening up those joints, make reduction a bit simpler. I think what Dr. Raj was mentioning, he kind of starts with the second TNT joint, which I agree. I think stabilizing that joint, I think everything is really based off of that keystone, getting that second TMT joint back in alignment. I kind of look at one and two the same. I guess if I were to technically say I do second TMT joint, first TMT joint, and then down the line three, four, and five. But I kind of look at one and two the same. So technically speaking, I'm kind of doing both at the same time. Because I think, as I mentioned, what in my part of the talk, reduction of one and two is really the most important, and then everything else is based off of that.
Another point I was going to make as well is sometimes you have to maybe resect a little bit of bone to be able to move things freely. Sometimes I've used distractors preemptively to free things up, to move things in line. So you have to work on that part too. It won't just sort of fall in place.
Agreed.
Good point. All right. 68-year-old male with, he just stepped off the curve. He's a mess. He's BMI is 32, but neuropathy up to the knee. Skin is atrophic, one of those shiny ones. And he has a history of full-foot ulcer as a diabetic patient and chronic kidney disease. Um, what's your plan?
My plan is think I'm glad they're in Texas, Hero. That's
Right.
my plan.
This is one of those cases where just using minimal incision, provisional wires to really stabilize things as best you could, and maybe leaving that in place initially uh, was a good option because there's always this threat of a Charcot episode happening with, a lot of trauma or incisions or whatnot. But ultimately, the neuropathy is a concern. Obviously, sometimes the bone quality is not great. Fusions can fall apart. So these are challenging cases. They're usually just a combination of immobilization and as much provisional fixation as you can get in, and then maybe later going on. Um, but you also have to think sometimes a lot like this is a more of a Charcot type case, where you have to think a super construct, something that expands beyond just the Lisfranc region to give you stability. So those ideas also can come into play as well when it comes to definitive fixation.
Yeah, the energy was certainly low. It just stepped off the curve and you
Yeah.
got this, so must be some kind of underlying metabolic issues. Yeah.
Yeah, you also have to ask yourself if being I don't know if you said they were diabetic, but you said they were neuropathic. How much of this was what it started with before they stepped off the curb, right? I mean, sometimes we see these cases where, you come in and they have horrible Charcot and but they don't have any problems, and then they trip and fall, and all of a sudden you have to determine, all right, what do they start with and what is new? And I think that can be a challenging part. But I agree with Dr. Roger there. Sometimes providing temporary fixation, letting things calm down, assuming depending on how acute these things are, how much swelling there is, and then ultimately kind of determining, what's the stability of this foot, and determining, you may get this to a point where the swelling comes down, the acute inflammation comes down, and the foot's stable. It may not look pretty, but it may be stable, and it's maybe reasonable to leave it as it is until it becomes unstable or unbraceable or unchewable, and then or they start developing some ulcers, and then you have to start talking about definitive fixation. But a super construct obviously is something that you have to think about for this patient.
Uh, that's kind of what I did. I'm just made two small incision distally and just threw a nail or a screw, whatever you want to call those. But I didn't, obviously, I just didn't want to end in the cuneiform, so I just went through
Yeah.
all the way to the talus. Um, so this patient actually died in a couple of years, 2 years. So if you notice, I didn't even care about fixing the third metatarsal neck fractures. But this was, purely salvage procedure, and so he got to walk a little bit the last 2 years of his life.
Yeah, here
Yeah.
I think that's a great option, especially spanning it up
Yeah.
into the TN joint. I think that's probably the best way to do it.
Yeah. Very small incisions, it's super construct, good fixation that has some, some strength to it. A smart move on your part. Neuropathy can be double-edged sword. Sure, it can affect bone quality and fusion, but it also is neuropathy. They don't feel it as much, and so sometimes their quality of life is not as horrible as long as you have something that is stable.
So we only have 5 more minutes. So just kind of rapid fire cases. This was actually from last week, 26-year-old female. As you can see, bilateral weight-bearing films. You can see that gapping on the left one. The little tricky thing is that I was actually I scheduled this for percutaneous fixation. You could argue that tarsal metatarsal first tarsal metatarsal joint is dislocated too, subluxed. So I scheduled for that, but the patient could not have surgery because she had to take care of her mom, um, and she couldn't have surgery for 6 weeks. So now it's no longer an acute case. Do you change your plan at this point?
Was she off of it at that time, or was she
So
had to?
I offer the percutaneous open reduction internal fixation. So syndesmotic screw, not syndesmotic, the Lisfranc screw, and
Yeah,
possible plating of the first tarsal metatarsal joint, the bridge plating without fusion.
yeah,
Yeah, I think 6 weeks is sort of that cutoff where you technically look at acute versus chronic. Uh, I think I think you would have ultimately a very low success trying to do a percutaneous or ORAF. I'd probably lean more towards a fusion in this case. If it's 6 weeks out, probably walking on it, probably relatively unstable, assumingly arthritic change is happening already. So I'd probably lean more towards fusion.
yeah. I mean, if she could not stay off of it and she's walking on it and she's feeling pain for that period of time, then you're
Actually, she actually stayed off. She has
okay.
no pain at this point. So she was in the knee scooter taking care of her mom, and so 6 weeks later, she has no pain, no edema, no ecchymosis.
Wow.
Yeah. So,
She should have
I
just had the surgery if she was going to stay off of it for six
Yeah.
weeks.
that's right.
Yeah.
Intraoperatively, I tend to see if I can look at the joints too, just clean them out, like Dr. Sachs was saying, it does help to clear them out. But typically, in this case, I may consider at that point some sort of maybe perimeter plating or bridge plating or AF.
So still
Maybe not
offer RIF at this point, 6 weeks?
intraoperatively. Sometimes the decision is made for me by looking at what I'm observing, what I'm looking at. If I think the joints demonstrate some sort of, cartilage degradation or damage, then I may consider fusing it, but I leave the option open. But in this case, she's not putting weight on it. She's kept off of it. It's just been displaced for 6 weeks, though, so you do have this sort of uneasy feel for the contact pressures in the area. But possibly, yeah. I mean, fusion ideally, I think, would be the predominant sort of thought process, but I wouldn't be opposed to it.
I actually did open reduction internal fixation with flexible Lisfranc and just the plating on the first tarsal metatarsal joint. So instead of percutaneously, I actually opened it and
Yeah.
freshened up the edges. There was, a lot of scars already, so I just run draw those out and did this. Do you think it has a chance, or I should have fused it?
You want me to tell you offline what I think, or no, I'm just kidding. No, no, I think it's perfectly reasonable. I think the key part here is that you opened it. I think
Yeah.
trying to do this percutaneous would be very, very difficult.
Yeah.
You got great reduction there. I think it's 100% reasonable to try it. I think just patient obviously has to know that 6 weeks out, the likely success long term, especially being 26, she's probably going to get some arthritis there. So.
Yeah. I think percutaneous for us was typically the patient that was in no way, shape, or form a good, healthy candidate. We just want to get something in place to get some sort of reduction. But typically, opening it was a key to achieving the goal of anatomic reduction. I think you have to be able to see it. And so at that stage of the game, you can always talk to your patients about the fact that over time, it's not a quick sort of fix. It's not the point in time you'll see me. We'll have to move forward and see how far you get with this, but there's always the possibility of a staged fusion. So I think it's a reasonable conversation if you elect to go with an open reduction to fixation. You've had that conversation, and they're thinking that as well if things don't quite work out based on their experience with how they do in the first year of this injury.
Post-op course for this. I mean, she's already non-weight bearing for 6 months. I don't know, 6 weeks. Another 20 weeks, or what do you think? The flexible fixation that you both don't like.
Don't like primarily. I like long term.
Primarily, yeah.
I mean, I
Yeah.
think non-weight bearing for 8, 10 weeks is I think pretty reasonable for this case. Um, obviously depending on symptoms and swelling and those types of things, but I'd probably lean closer to the 2 month range in a patient like this.
Yeah, I think protected weight bearing for me, I let the patients kind of know that pain is your gauge. If you're doing something too much on it, it gets sore, it gets swollen. Obviously, you have to back off of it, but I'll protect them and let them weight bear as tolerated based on things they need to do. But initially, I do keep them off of it. I typically give them a knee scooter or a knee rollator so they can stay off of it. I have them still do range of motion because typically you'll find sometimes if they're off it for too long, they end up with insertional tendonitis of the Achilles or even plantar fasciitis in the long run, just from the tightness that forms. So I have them stay as flexible as possible with range of motion, but eventually transition to protected weight bearing until about maybe the 4 month mark, and then base it off of that based on, attempts at weight bearing in the shoe and see how things go. But no high impact activity, obviously, running, jumping, that kind of thing.
Yeah. Well, I don't know what's gonna happen, but this was from last week, so um, we'll let you know. All right, so we're kind of out of time, but just one question. This was kind of not so subtle, but he had to try him out at the same time, so I didn't want to keep him non-weight bearing for too long. So this is the case where I actually fused it. I think they actually go back to weight bearing much quicker if you fuse it. So it's the case I fused it. That was a point that I wanted to make, but. One question I have is that do you like these plates? I mean, how do you dissect it? How do you do the dissection to fit that thing in there? I mean, I always have to, you know, get scared going under that neurovascular bundle and try to fit that thing in there. Do you think it's worth it? I mean, it's obviously more stable than two separate plates, but
Yeah, I mean, it's definitely stable. It's definitely extra articular. The downside, as you mentioned, is that if you have to remove these things, you have to go back and almost approach it the same way you did when you put them in. And I've had a few cases where these plates were in the long run too stiff. People actually felt like it was too rigid of a construct. So that can happen in some situations. But overall, though, you definitely achieve stable fixation with these things. So they're a good option, but they do have some limitations in the long run.
I can't say I've had that many issues with it. You know, it works. They achieve good fusion. It's good stability. I agree. Obviously, there's a fair amount of dissection, but in some of these cases, I think you need that dissection to really reduce these appropriately, so. Yeah, it's a concern. I can't say I've ever looked back and said, "Man, I wish I never used that plate." But I hear what you're saying. But I think in some cases they are truly
Yeah.
necessary given the severity of some of these injuries.
I generally do prefer them, just as a follow-up. I do prefer them, but the more you put in, the more you realize there are some things about them that do come up. So
maybe I should skip
everything's
some holes instead of filling all the holes.
That's right.
All right. So one more question. I guess thanks everyone. Great talk. All right. Great job, guys. Thank you very much. Any other questions?
Folks, I apologize for my internet connection. I'm just surprised it did that, but my apologies.
Okay, just to summarize, obviously, there we talked about trend in Lisfranc's surgery, but not all Lisfranc's injuries are the same, and there are many factors that goes into the decision making of arthrodesis versus open reduction and internal fixation, and type of fixation used for different cases. So we kind of touched on a lot of the factors that is associated with the decision making. And with that, postoperative management also changes. Open reduction internal fixation versus arthrodesis certainly changes things, and type of fixation, flexible versus solid fixation makes difference. So I think we touched a lot on those things. So if you have no other questions, thank you for your attention. I know it's like almost 10 o'clock in the East Coast, but we like to see a lot of you at the actual AO courses. So similar format, but we do have actual hands-on part of it. So that's the only difference, really. We go over cases, we have didactics, but we also do some hands-on workshop too. So hopefully I'll see a lot of you at the actual in-person meetings. Thank you.